Akshit,
గుడ్ మార్నింగ్ సార్.
good morning. పంపించావు మనల్ని.
సార్ ఇవ్వండి ఐపీఎల్లో మన మార్క్ దగ్గర
ఓకే,
ఎక్స్పెక్ట్ చేద్దాం మీరు వచ్చిన
నేను వచ్చినా చేద్దాం.
సరే.
Hello.
Hello.
Morning, sir. David,
Good morning,
good
sir.
morning.
Good morning, madam. Madam, shall we start?
మీరు చెప్పండి.
Sir.
Enough people ఉన్నారంటే స్టార్ట్ చేద్దాం.
David start చేయండి.
Okay, sir. Good morning, all of you. Coming to the continuation of the neurological disorders. Previous class it was on Guillain-Barré syndrome by Sharath. Now, today Dr. D. Gauri Mahesh is going to talk on Myasthenia Gravis and Myasthenic crisis. I request Dr. Lakshmi Rani Madam to introduce Dr. Mahesh. Madam.
Hello. Hi, good morning all. Today, Dr. Gauri Mahesh, our IDCCM student, he is going to talk on Myasthenia Gravis and Myasthenic crisis, differential diagnosis, and Myasthenic and cholinergic crisis differences, and all these things. He did his MBBS from Kakinada, and he did his MD. Mahesh, am I telling right?
Ashram Medical College.
Okay, MBBS MD in Ashram Medical College, and now he's doing his IDCCM here. So, Mahesh, start your class.
Thank you very much, madam. Good morning, one and all. Today, my topic is Myasthenia Gravis and Myasthenia crisis. Coming to introduction, it is a acquired autoimmune disorder clinically characterized by weakness of skeletal muscle, fatigability on exertion. First clinical description was given by Thomas Willis in 1672. Coming to prevalence, it is 2 to 7 in 10,000 population. It affects all age groups. Usual age at onset is 20 to 30 years of age in females, 50 to 60 years in males. Overall female preponderance occurs. Familial occurrence is known but rare. More common is a family history of one or other autoimmune diseases and suggests partial genetic predisposition. Coming to pathophysiology, this is autoantibodies to ACH receptors protein. 85% of patients with generalized myasthenia and 50% with ocular myasthenia shows anti-ACHR antibodies. Anti-MuSK antibodies, it is 40% of seropositive cases. An immune response to muscle-specific kinase can also result in myasthenia gravis, possibly by interfering with ACHR clustering. These antibodies block the binding of ACH to ACH receptors, which increases the degradation rate of ACH receptors. These antibodies leads to cross-linking of receptors, leads to endocytosis and degradation of ACH receptors. As a result, these synaptic folds are simplified and decrease the synaptic clefts. a complement mediated destruction of postsynaptic folds occurs. The latter two mechanisms would be expected to reduce the number of ACH receptors at the synapse. This diagram shows the normal NMJ. It shows the acetylcholine, which acts is produced from the presynaptic terminal, released into synaptic cleft, and then act on the ACH receptors. Coming to myasthenia gravis, in this, autoantibodies are produced against the ACH receptors. ACH receptors. As a result, destruction of ACH receptors in the postsynaptic muscle terminal, and as a result, these synaptic folds become simplified and decrease number of ACH receptors, and synaptic fold become simplified and decrease the clustering and action. Thymic and other associated disorders. Thymus is abnormal in 75% of patients with myasthenia gravis. In 65% of 65%, the thymus is hyperplastic. 10% of patients have thymic tumors. Thymomas with malignant characterized by local spread. Upon distant spread to lungs and liver. Muscle-like cells called myoids within the thymus, which bear ACH receptors on their surface. These may trigger an immune response. Coming to pathological features of the thymus. Hyperplasia of medulla characterized by lymphoid follicles with active germinal cells. The cells in the center of follicles called histiocytes. IgG is elaborated in the germinal follicles. Two forms of thymomas described. One is histiocytic variety, second one is lymphosarcomatous variety. Coming to clinical presentation of myasthenia gravis, repeated and persistent activity of muscle group exhausts its contractile power, called fatigability, leading to a progressive paralysis, and rest partially restores the strength. There is special vulnerability of certain muscle groups. Eyelids, extraocular muscles, face, jaw muscles, throat, neck muscles are first to be affected. Limb muscle weakness as the initial complaint is less frequent. Fluctuating weakness increased by exertion. Weakness increases during the day and improves with rest. Ptosis diploplasia is a presenting symptom in 50% of patients, increased during course of disease in 90% of patients. If pupils are spared, if associated with weakness of closure, it is almost diagnostic of myasthenia gravis. Head extension flexion weakness, more sensitive in demonstrating generalized myasthenia. Coming to Wasserman-Jenkins classification. Class 1, it is exclusively ocular muscle weakness called ocular myasthenia. Class 2 is a mild weakness other than ocular. Class 2 again divided into 2A and 2B. In class 2A, predominantly limb axial or axial muscles are involved. In 2B, predominantly oropharyngeal and respiratory muscles are involved. Class 3 is a moderate weakness other than ocular. Again 3A and 3B. 3A predominantly limb axial or both. 3B predominantly oropharyngeal or respiratory muscles. Coming to class 4, it is a severe weakness other than ocular. 4A, 4B. 4A predominantly limb axial or both. 4B predominantly oropharyngeal or respiratory muscles. Coming to class 5, which requires intubation with or without ventilation. This table shows predict the quantitative myasthenia gravis score. In this, parameters are double vision on lateral gaze, ptosis on upward gaze, facial muscle weakness, swallowing difficulties, speech after counting a loud from 1 to 50, right arm outstretched hand, left arm outstretched, percentage predicted vital capacity, right hand grip, left hand grip, head lifted in seconds, right leg outstretched in seconds, right leg outstretched in second in supine position. It is graded as mild, moderate, and severe. In ptosis, if in mild, it is 11 to 16 seconds upward gaze. Facial muscle weakness, In normal lid closure occurs. If the lid closure is complete with some resistance, it is mild. Lid closure is complete without resistance is moderate. Lid closure is incomplete, that is the severe. Swallowing of water with normally in minimal disease, minimal coughing and throat clearing. Swallowing of water in moderate disease is severe coughing, choking or nasal regurgitation. If swallowing of water cannot swallow the water, it is a severe disease. Progression of disease, mild to severe for a weeks to months. Spreads from ocular to facial muscles and then to bulbar muscles and then to trunk and limb muscles. Symptoms may remain limited to extraocular muscles and lid muscles for years. The danger of death from generalized myasthenia is greatest in the first year after onset of the disease. A second period of danger is progressive cases is from 4 to 7 years after onset. After this time, the disease tends to be stabilized and risk of severe relapses diminishes. Ocular muscle weakness. Weakness of eyelid muscles can lead to ptosis. Ptosis is most common presentation. Ptosis is caused by the levator palpebrae weakness. Sustained upward gaze for 30 seconds. It usually affects more than one extraocular muscle. Diplopia is the second most common. Bright sunlight aggravates the ocular signs and cold improves the ocular signs. Facial muscle weakness is almost always present. Bilateral facial muscle weakness occurs. Sclera below limbus may expose it due to weak lower eyelids. Family members may notice that the patient lost his or her smile as a result of weakness of orbicularis oculi muscle. Orbicularis oris muscle. Coming to bulbar muscle weakness, more in anti-musk antibody positive cases. Palatal muscle weakness, nasal voice, nasal regurgitation, chewing may become more and more difficult. Severe jaw weakness may cause jaw to hang open. Swallowing may be difficult and aspiration may occur with fluids, coughing and choking while drinking. Neck flexors muscles are affected more than the extensor. The weight of head may overcome the extensor, particularly late in the day, producing dropped head syndrome. Limb muscle weakness, upper limbs are more common than the lower limb muscles. Proximal muscles are more affected than the distal muscles, which is usually asymmetric weakness. Coming to respiratory muscle weakness. Respiratory muscle weakness that leads to respiratory insufficiency. Impending respiratory failure is a life-threatening situation called myasthenic crisis, which is a neurocritical emergency. Weakness of intercostal muscles and diaphragm may result in CO2 retention called hypercarbia due to hypoventilation. Weakness of pharyngeal muscles may collapse the upper airway. Monitor the vital capacity and tidal volume. Do not rely on the pulse oximeter. Arterial blood oxygenation may be normal while CO2 is retained. As the disease progresses, it can involve the external sphincters of the bowel and bladder. A temporary increase in weakness may follow vaccination, menstruation, and exposure to extremes of temperature. Weakened muscles, but never go for atrophy. Deep tendon reflexes are retained till late. Smooth cardiac muscles are not involved. Tongue may display a single central and two lateral longitudinal furrows called trident tongue. Symptoms may appear first during pregnancy, puerperium, and in response to drugs used during anesthesia. Coming to differential diagnosis, neurological conditions which mimic the myasthenia gravis. Condition, amyotrophic lateral sclerosis, asymmetric muscle weakness and atrophy. In botulism, which is a generalized limb weakness. In Guillain-Barré syndrome, symmetric ascending limb weakness. In inflammatory muscle disorders, proximal symmetric limb weakness. In Eaton-Lamberton syndrome, proximal symmetric limb weakness. In multiple sclerosis, bilateral internuclear ophthalmoplegia. In periodic paralysis, intermittent generalized muscle weakness. Thyroid disorders, congenital myasthenic syndrome, brainstem syndrome, and encephalitis. Coming to disorders of neuromuscular junction, along with Eaton-Lamberton syndrome and botulism, cholinergic crisis, OP poisoning, spider and snake poisoning, primary muscle diseases, acid maltase deficiency, rhabdomyolysis, poliomyositis, Duchenne muscular dystrophy. These mimic the myasthenia gravis. Systemic diseases like hypothyroidism, hypophosphatemic myopathy, hypo or hyperkalemic periodic paralysis, electrolyte disturbances may also mimic the myasthenia gravis. Coming to Eaton-Lamberton syndrome, it is a presynaptic disorder of NMJ. In this, antibodies are produced against the PQ type of calcium channels at the motor nerve terminal. Impaired release of ACH from the nerve terminal. The muscle weakness similar to myasthenia gravis, proximal muscles are more affected. Cranial nerve involvement is also there in 70% of patients. But depressed or absent reflexes seen, autonomic disturbances seen, incremental response to repeated nerve stimulation. These Eaton-Lamberton syndrome associated with small cell carcinoma, treatment by immunosuppression, plasma paresis, and pyridostigmine. This table depicts the comparison of myasthenic syndrome and myasthenia gravis. Manifestations in myasthenic syndrome mostly proximal limb weakness, legs more than the arms, but exercise improves the strength. Muscle pain common. In myasthenia gravis, extraocular muscle, bulbar facial muscles involved, but exercise causes fatigability. Muscle pain is uncommon. In myasthenic syndrome, reflexes are absent or decreased. In myasthenia gravis, reflexes are normal. In myasthenic syndrome, male preponderance seen, but in myasthenia gravis, female preponderance is seen. Myasthenic syndrome associated with small cell lung cancer. Myasthenic gravis associated with thymoma. In myasthenic syndrome, response to muscle relaxation is sensitive to scoline and non-depolarizing muscle relaxants. In myasthenia gravis, resistant to scoline and sensitive to non-depolarizing muscle relaxants. In myasthenic syndrome, poor response to anticholinesterases. In myasthenia gravis, good response to anticholinesterases. Coming to autoimmune diseases, coexisting autoimmune diseases, Hashimoto's thyroiditis and thyrotoxicosis occur in 5 to 10% of myasthenic gravis patients. Weakness may not improve with treatment of myasthenia gravis alone in patients with coexisting hyperthyroidism. Other autoimmune disorders like rheumatoid arthritis, scleroderma, lupus erythematosus, jargon, mixed connective tissue diseases, polymyositis. Coming to myasthenic crisis, myasthenic crisis is a neurocritical care emergency. It is in this severe weakness of bulbar respiratory muscles causing inability to maintain adequate ventilation and or permeability of upper airway called respiratory failure, requiring artificial airway or ventilatory support. Post of myasthenic patients, extubation has been delayed for more than 24 hours. The myasthenic crisis patients comes under class 3 or 4 of Wasserman-Jenkins classification. Predisposing factors of myasthenic crisis: respiratory infections in 40% of patients, emotional stresses, microaspirations, changes in medication regimen, surgery or trauma. Drugs like antipsychotics, neuromuscular blockers, anticholinergic drugs, antibiotics, aminoglycosides, macrolides like telithromycin is an absolute contraindication in myasthenic crisis patients. Penicillins and other drugs like anti-rheumatological and immunosuppressants, cardiac medications like beta blockers, verapamil, statins, these all are predisposing factors for myasthenic crisis. Coming to pathophysiology of myasthenic crisis, these acetylcholine receptors are released into synaptic cleft. These act on the acetylcholine receptor, ACH receptors on the postsynaptic membrane or muscle terminal. These causes destruction of these ACH receptors. As a result, these synaptic folds become simplified and decrease response. In postsynaptic muscle, triggering the muscle action potential propagated by voltage gated sodium channels. Anticholinesterase enzyme break down the unbound acetylcholine. In a separate pathway, neurolegrin binds to muscle specific kinase, initiating clustering of phosphorylated rhabdin and ACH receptors, stabilizing postsynaptic structure. These egrin binds to muscle specific kinase receptors and clustering of these ACH receptors and rhabdin protein maintain the postsynaptic structure. Musk initiates the clustering of cytoplasmic protein rhabdin and acetylcholine receptors and is believed to maintain their normal postsynaptic architecture. The molecular physiology of myasthenia gravis caused by antibodies to ACH receptors. There is a blockade of binding site of ACH, cross-linking of ACH receptors with subsequent internalization, reduction in its surface expression, initiation of complement and cellular inflammatory cascade, damage to post and presynaptic structures. The molecular physiology of myasthenia gravis mediated by antibodies to MuSK has not been established. Coming to pathophysiology of myasthenia gravis crisis, in myasthenic crisis, weakness of bulbar muscles causes accumulation of secretions called oropharyngeal lake and alteration of sigh mechanism, cough and swallowing reflexes. As a result, atelectasis, microaspiration, increase upper airway resistance causes increased work of breathing. It causes pneumonia. Respiratory muscle weakness leads to decreased tidal volume and FRC. As a result, increased hypoventilation, increased dead space, and VQ mismatch leads to hypoxemia, hypercapnia called respiratory failure. Clinical features of myasthenic crisis: dyspnea, orthopnea, tachypnea, tachycardia, sweating, use of accessory muscles of respiration, or paradoxical ventilation. Collapse of airway is marked by coughing, swallowing disability, leading to accumulation of secretions in the pharynx. Patients are unable to count until 20 in a single respiratory cycle. Clinical test, ice pack test can be used in patients with ptosis, particularly those in whom hydrophorium test is considered to be too risky. It is based on the physiological principle of improving neuromuscular transmission at lower muscle temperatures. In the ice pack test, the bag is filled with ice placed on the closed lid for 2 minutes. The ice pack is then removed, then extent of ptosis is immediately assessed. The sensitivity of test is 80%. Hydrophonium test or Tensilon test is used most commonly for diagnostic testing because rapid onset within 30 seconds and short duration within 5 minutes of its effect. An initial dose of 2 mg hydrophonium is given. If definitive improvement occurs, the test is considered positive and is terminated. If there is no change, the patient is given an additional 8 mg hydrophonium. This test is now reserved for patients with clinical findings that are suggestive of myasthenia gravis, but who have negative antibody and electrodiagnostic test results. Coming to serological testing, anti-AChR antibodies detected in 85% of myasthenic patients, but in only about 50% of patients with weakness confined to ocular muscles. The presence of anti-AChR antibodies is diagnostic of myasthenic gravis, but a negative test does not exclude the disease. Anti-MuSK antibodies have been found to be present in 40% of AChR antibody negative patients. A small proportion of myasthenic gravis patients without antibodies to AChR or MuSK antibodies may have antibodies to LRP, lipoprotein receptor protein 4, although a test for LRP4 antibodies is not yet commercially available. Finally, antibodies against gangrene have recently been found in some patients with myasthenia gravis. Coming to imagology CT chest to roll out the thymomas. EMG electromyography, single fiber electromyography measures the electrical potential of muscle cells when the single muscle fiber are stimulated by electrical impulse. Muscle fibers in myasthenia gravis as well as other neuromuscular disorders do not respond to electrical stimulation compared to muscles from normal individuals. Repetitive nerve stimulation. This test records the weakening of muscle responses when nerves are repeatedly stimulated by small pulses of electricity. Repetitive nerve stimulation, the decrement of amplitude of more than 50% at a 3 Hz frequency is probable of myasthenia gravis. In normal compound muscle action potential, there is no decrement in amplitude in response to repeated stimulation. In myasthenia gravis, decline of amplitude with repeated stimulation because fewer muscle fibers in motor unit are firing action potential. Algorithm for myasthenic crisis management. Myasthenic crisis. You confirm diagnosis, admitted in ICU. Without previous diagnosis, first confirm the diagnosis and admitted in ICU. If myasthenic gravis previously diagnosed, first stop the anticholinergics and continue the immunosuppressors. In a critical care, first general critical care and avoid the complication and treat the systemic complications. Search for any precipitating factors. Evaluate the bulbar and respiratory functions, and then specific immunotherapy, plasmapheresis, IV agent, corticosteroids. Finally, requirement of ventilator support. Intubation and mechanical ventilation. Bedside measurements like vital capacity, peak expiratory flow rates, pulse rate, BP are more important than the repeated blood gas analysis. Ventilatory tests in patients with myasthenic crisis. Normally, FEC is more than 60 ml per kilo. NIP is more negative inspiratory pressure of more than minus 70 centimeter of water. Positive expiratory pressure of more than 100 centimeter of water. For coming to intubation criteria, 20, 30, 40 rule is in less than 20%, less than 20 ml per kg FEC, less than minus 30 centimeter of water NIP, less than 40 centimeter of water, positive expiratory pressure is there, then is guide for intubation criteria. Coming to extubation criteria, FEC of more than 25 ml per kilo, NIP of more than 40 centimeter of water, PEP of more than 50 centimeter of water to guide the extubation. These are 20, 30, 40 rule. FEC less than 30 ml per kilo associated with ineffective cough, poor handling of secretions, atelectasis, and hypoxemia occurs. Negative inspiratory pressure of less than 20 centimeter of water signals marked weakness of inspiratory muscles and diaphragm. PEP of less than 40 centimeter of water indicates involvement of expiratory muscle function closely linked with ability to cough and clear the secretions. This is called 20, 30, 40 rule. Ventilation strategies in myasthenic crisis. Initial mode of assist control ventilation with low tidal volume and low PEP of 5 to 5 centimeter of water. FiO2 should be adjusted to achieve a SaO2 of more than 92 centimeters, 92%, PaO2 of more than 70 mm of Hg. Pressure support ventilation between 5 to 15 centimeter of water is another option. In atelectasis, we consider recruitment maneuvers, the utilization of psi maneuvers. The degree of support is patient dependent, should be adjusted and based on ABG analysis. In patients with chronic hypercarbia, PaO2 should be kept above 45 mm of Hg to avoid alkalosis and bicarbonate wasting, which make weaning is more difficult. Bronchodilators may be useful to maintain the airway patency and overcome bronchospasm by inhaled ipratropium bromide. Meticulous attention to pulmonary toilet. Aggressive chest physio is required, percussion, vibration, and postural drainage, PVD, and airway clearance by regular suctioning and therapeutic fiber optic bronchoscopy in severe cases. Maintain inspired gas humidity should be around 80% at 37 degrees centigrade. Patients with peak cough flow less than 180 liters per minute can augment the cough response with manual physiotherapy and with insufflation, exsufflation devices. Cough response increases and is associated with improved prognosis independent of FVC or breathing pattern. Coming to adequate nutrition is important to avoid negative energy balance and worsening of muscle strength. Adequate nutrition is considered or recommended. All patients should receive adequate nutritional support, 25 to 35 calories per kg via enteral route whenever possible. In patients with hypercarbia and difficult weaning, low carb feeds are the preferred solution. Potassium, magnesium, phosphate depletion can exacerbate the myasthenic crisis and should be replenished. Anemia can also increase weakness. Several experts recommend transfusion when hematocrit is less than 30%. These patients are mostly bedridden, hence DVT prophylaxis is recommended, is very important. Hemodynamic stability, glycemic control are strongly recommended. BiPAP, positive pressure applied during both phases of respiratory cycle enhancing the airflow, alleviating the work of breathing during inspiration, preventing airway collapse and atelectasis during expiration. Weaning difficulties and need for reintubation are commonly encountered. Consider tracheostomy in these patients. Many of them need home BiPAP support also. Coming to complications in management of myasthenic crisis, fever, infections, infectious complications like pneumonia, bronchitis, UTI, Clostridium difficile colitis, bacterium and sepsis. Deep vein thrombosis. Cardiac complications include congestive heart failure, acute MI, arrhythmias, and cardiac arrest. Stop anticholinesterase drugs. They are unnecessary in this situation, may complicate pulmonary management, and continued use of these medications may promote the cholinergic crisis by overdose. Cholinergic crisis may cause increase of pulmonary secretions called due to muscarinic effects, fasciculations due to nicotinic effects. Both of these contribute to exacerbation muscle weakness, respiratory failure, may promote the cardiac arrhythmias and MI. Time to restart the cholinergic agents like pyridostigmine when the patient shows clinical improvement before weaning of mechanical ventilation. Then restart cholinergic agents. Coming to difference between myasthenic crisis and cholinergic crisis. Myasthenic crisis is due to exacerbation of myasthenia gravis, which is due to inadequate treatment or stresses, trauma, infections. Cholinergic crisis is due to excessive anticholinergic treatment. Heterophonian test is not recommended in myasthenic crisis patients because there is a likelihood of false positives and false negatives. In heterophonian test is worsening occurs in cholinergic crisis. Muscarinic symptoms absent in myasthenic crisis patients, muscarinic symptoms present in cholinergic crisis. In myasthenic crisis, anticholinesterases treatment is anticholinesterases with atropine, mechanical ventilation, antibiotics, IV fluids, plasmapheresis, and IVIG. In cholinergic crisis, treatment is stop the anticholinesterase and give atropine, mechanical ventilation, and pralidoxim 500 mg IV infusion. This treatment of myasthenia gravis, first anticholinesterases, immunosuppressants, plasmapheresis, IVIG, thymectomy in thymoma patients. Anticholinesterase medication. Coming to some anticholinesterase drugs, pyridostigmine is most commonly used drug, anticholinesterase drug. The beneficial action of oral pyridostigmine begins within 15 to 30 minutes, lasts for about 3 to 4 hours. Treatment is begin with a moderate dose, 30 to 60 mg, 3 to 4 times daily. The maximum useful dose of pyridostigmine rarely exceeds 120 mg every 4 to 6 hours during daytime. In some patients, muscarinic side effects of anticholinesterase medication like diarrhea, abdominal cramps, salivation, nausea may limit the dose tolerated. Mycophenolate mofetil dose is 1 to 1.5 grams twice daily. Azathioprine initial dose is 50 mg per day, gradually to about 2 to 3 mg per kg of total body weight until the WBC count falls to 3 to 4,000 per microliter. Cyclosporine is 4 to 5 mg per kg per day, and the average dose of tacrolimus is 0.07 to 0.1 mg per kg per day, given in 2 divided doses. Coming to rituximab. Rituximab is a monoclonal antibody that binds to CD20 molecule on B lymphocytes. It is particularly effective in MuSK antibody positive myasthenia gravis, although some patients with ACH receptor antibody myasthenia gravis responds to it as well. The usual dose is 375 mg per ml given in IV in 4 weekly infusion, or 1 gram given IV on 2 occasions 2 weeks apart. Coming to immunosuppressives, choice of drugs or other immunomodulator treatment should be guided by the relative benefits and risks for the individual patient and the urgency of treatment. If immediate improvement is essential because of severity of weakness, IVIG or plasmapheresis should be undertaken. For the intermediate term, glucocorticoids, cyclosporine or tacrolimus generally produce clinical improvement within a period of 1 to 3 months. The beneficial effects of azathioprine, mycophenolate mofetil usually begin after many months, but these drugs have advantages for long-term treatment of patients with myasthenia gravis. Coming to glucocorticoids, glucocorticoids indicated in myasthenia gravis crisis when the patient cannot be extubated 2 weeks after specific immunotherapy. It may be initiated concurrently with IVIG or plasmapheresis since prednisolone begins to work after 2 weeks. Myasthenia gravis, prednisolone should be given in a single dose rather than a divided dose throughout the day. The initial dose should be relatively low, 15 to 25 mg per day. The dose is increased stepwise as tolerated by the patient, usually by 5 mg per day at a 2 to 3 days intervals, until there is a marked clinical improvement or a dose of 50 to 60 mg per day is reached. The dose is maintained for 1 to 3 months, then gradually modified to an alternative date regimen over the course of additional 1 to 3 months. Coming to plasmapheresis, plasma which contains pathogenic antibodies is mechanically separated from blood cells which are returned to the patient. A course of 5 exchanges, 3 to 4 liters per exchange is generally administered over a 10 to 14 days period. These plasmapheresis produce short-term reduction in anti-AChR antibodies with clinical improvement in many patients. Coming to IV immunoglobulins, this treatment has been advantages of not requiring special equipment or large bore venous axis. The usual dose is 2 gram per kg, which is typically administered over 5 days, or 400 mg per kg per day. Improvement occurs in 70% of patients beginning during treatment within a week and continuing for weeks to months. Adverse reactions are generally not serious, but may include headache, fluid overload, and relay aseptic meningitis or renal failure. Thymectomy is indicated in failure of long-term conservative therapy and thymoma patients, new onset of generalized myasthenia gravis. Patients with more benefits after thymectomy are those less than 60 years, seropositive, and with thymic hyperplasia. Whenever there is established diagnosis of myasthenia gravis, search for associated conditions. In ocular myasthenia, MRA brain, then start the anticholinergics like pyridostigmine. In generalized myasthenia, start the anticholinergics pyridostigmine and evaluate the thymectomies. In myasthenic crisis patients, ICU admission due to respiratory infection, treated with IV fluids, IV antibiotics, plasmapheresis, IVIG. Evaluate the clinical status. If indicated immunosuppressants, then give the immunosuppression for short-term, intermediate, and long-term treatment. These are the short-term, intermediate, and long-term treatment. Thank you.
Thank you, Mahesh, for presentation. Any questions?
Thank you, doctor, and thank you, David. Nice class. I have a question. Doctor, hello?
Sir.
Able to hear, no?
Sir, audible, sir.
A patient who underwent surgery for trauma, for abdominal intestinal obstruction. Patient had an intestinal obstruction, so he underwent surgery, and he got aspiration pneumonia, and he was in ARDS. And he was after 4 days. 4 days, 4 or 5 days, ARDS has improved. 5 days, and then now you ask the patient, you are given a deep sedation and 2 days of paralysis because he is in severe ARDS. After 5 days, he is improved. He is off sedation, and he is on ventilator, volume control ventilator, no sedation, no vasopressors, lung is fine. Now the patient is not moving any of the limbs. Okay, he is little drowsy, off sedation. Now he is not moving any of the limbs. Now, how will you investigate this patient?
Sir, how will you? Sorry, sir.
Investigate this patient and treat this patient. Quadriparesis is there.
First, we have to. Sir?
Patient is having quadriparesis.
Quadriparesis, yes, sir.
This is a common scenario we see in the ICU. How will you investigate now?
First, we have to evaluate the patient, sir, with the routine investigations in the and
You
any
ask
electrolyte
investigation,
disturbances.
No electrolyte disturbances. What
Electrolyte
electrolyte
disturbances
you
like
want?
hypokalemia, hypomagnesemia, hypophosphatemia to rule out,
No,
sir.
normal. All values are normal.
All are normal.
Next.
Then any spine involvement, sir. CT brain,
What you
MRI.
want to do?
CT brain, MRI, sir.
CT brain normal.
Clini-
MRI brain normal.
Clinical signs of any ocular involvement seen,
How
sir.
will you assess the clinical signs of ocular involvement in a patient on a ventilator?
Is off sedation, is sir? If
Yes,
it is
yes,
less
is
than
off sedation. How will you assess? What are
prolonged
the-
upward gaze, sir. Prolonged upward gaze, any ptosis. If the patient is conscious, any diplopia.
How will you assess diplopia in a patient who is on a ventilator?
If the patient is conscious and communicate with patients, sir.
Yes, he is not able to lift a hand and write.
Yes, sir.
Raghu, you all
People in-
residents are there, no? Everybody can interact. Because these are the common scenarios we see in the ICU.
Coming any requirement of any serological test to rule out the
What serological test you want to do? First see clinically and
to rule out any poisoning conditions, sir.
poisoning up.
To done the any clinical tests like
డాక్టర్లు నర్సులు ఏమైనా పాయిజన్ ఇస్తే తప్ప పేషెంట్ కి ఏమి ఇంటెస్టైనల్ అబ్స్ట్రక్షన్ ఆస్పిరేషన్ న్యూమోనియా ఏఆర్డిఎస్
reflexes, sir.
వాట్ రిఫ్లెక్సెస్ యు వాంట్ టు సీ
Deep tendon reflexes, sir.
డిటిఆర్ లో
DTR.
ఏమున్నాయి డీప్ సెంట్రల్ రిఫ్లెక్సెస్
We can also suspect critical illness myopathy in such case scenarios.
క్రిటికల్ ఇల్నెస్ మయోపతి ఓకే వన్ క్రిటికల్ ఇల్నెస్ మయోపతి నెక్స్ట్ myasthenia gravis ఓకే హౌ విల్ యూ ఎనీ అదర్ డిఫరెన్షియల్ డయాగ్నోసిస్ ఇన్ దిస్ పేషెంట్స్ రెసిడెంట్స్ ఉన్నారు కదా చాలా మంది సిటిజన్స్ నుంచి ఎవరు లేరా
Yes, sir.
లేరా సిటిజన్స్ నుండి రెసిడెంట్స్
సార్ ఎంఆర్ఐ స్పైన్ సార్
ఈ డిఫరెన్షియల్ డయాగ్నోసిస్ చెప్పు ఏమేమి ఉన్నాయి దే టోల్డ్ 2 డిఫరెన్షియల్ డయాగ్నోసిస్ myasthenia gravis అండ్ క్రిటికల్ ఇల్నెస్ న్యూరోపతి మయోపతి
జీబీఎస్ గులియన్బర్గ్
Cervical injury.
గులియన్బర్గ్
జీబీఎస్ సర్వైకల్ ఇంజురీ ఇంకా కాన్షియస్ ఉన్నాడు కదండి కాన్షియస్ ఉన్నాడు కదా పేషెంట్ ఇంకా
ఎనీ స్ట్రోక్ ఆల్సో సార్ ఇది స్ట్రోక్ కూడా పాసిబిలిటీ ఉంది బట్
Stroke.
క్వాడ్రిపేసిస్ తక్కువ ఛాన్సెస్ బట్
తక్కువ ఛాన్సెస్ ఉన్నాయి ఇంకా సెన్సరీ సిమ్టమ్స్ ఐ వాంట్ టు సీ ఏమైనా సస్పెక్ట్ చేస్తున్నావా ఒక లెవెల్ అనుకుంటున్నాను ఈ లెవెల్ అని
So transverse myelitis.
ట్రాన్స్ఫర్స్ మైలైటిస్
Multiple sclerosis.
మల్టిపుల్ స్క్లీరోసిస్ ఇంకా శ్రీనివాస్ గారు ఇంకేమున్నాయి ఆ డిఫరెన్షియల్ డయాగ్నోసిస్ దాన్ని యాడ్ చేయగలుగుతారా
Vertically Westnile encephalitis.
శ్రీనివాస్ యాడ్ చేసిన పక్కనే సింజు యాడ్ చేసిన ఒకటేలే
సరే ఓకే
పక్క పక్కనే ఉన్నారు
Sir, infective etiology is like Westnile encephalitis, Westnile virus.
ఓకే ఇంకా సరే ఒక్కొక్కటి ఎలా ఎవాల్యుయేట్ చేస్తారో చెప్పండి No, see, as a critical care specialist, we need to evaluate and we need to diagnose it. Okay, that is the most important. So, as it is only not a ragging, please don't think it's a ragging session. It's a learning for me and everyone. All the seniors, please add. Residents, answer, please.
drug order.
Macrolides.
Macrolides.
Macrolides can precipitate
Macrolides can precipitate weakness.
as in who are at the what diagnosed cases of myasthenia gravis.
No, మనకు డయాగ్నోసిస్ తెలియదు కదా. మరి డయాగ్నోసిస్ తెలియనప్పుడు మనం
For the first
Antibiotics also can cause muscle weaknesses, no, sir.
which antibiotics?
Polymyxin, aminoglycoside.
Okay.
Telithromycin.
Okay. ఇంకా రఘు, శ్రావ్య ఎట్లా ఇన్వెస్టిగేట్ చేస్తారు ఈ పేషెంట్ ని? డిడి చెప్పాము ఇన్వెస్టిగేషన్స్. పోనీ ఎగ్జామినేషన్ క్లినికల్ ఫైండింగ్స్, ఏ క్లినికల్ ఫైండింగ్స్ ఎటువైపు you will differential diagnose because you people are exam going equals
Sir,
to DM.
Specific sensory manifestations unte we should rule out GBS, sir. Areflexia, and we have to examine for areflexia and ascending type of paralysis. In that case, GBS would be the differential diagnosis.
We don't know this patient ascending or descending and manaku teliyadu kada. 4 days we have sedated, 2 days paralyzed.
So myasthenia, generally they'll have history also, sir, prior history. And as day progresses, the patient would have weakness progressing. And they can be, a tensilon test can be done to diagnose. And for higher causes or the brainstem causes, then we have to do the MRI.
So first what we'll do, you want to do MRI?
First,
no problem. You ask,
yes,
I will get it done. Okay, you want to do?
Because this patient has got intact consciousness and all. First, so major bleeds and strokes probably are ruled out, and patient has quadriplegia. So the lesion would probably start with the brainstem, and transverse myelitis will have a sensory level below which there would be muscle weakness and sensory symptoms, sir. Above that, the patient will have normal motor and sensory functions.
No. So you want to do MRI brain?
MRI brain and spine, sir.
Spine, sir.
Yes, spine.
Cervical spine.
Spine. Okay.
What you are suspecting cervical spine, Raghu? Here?
Sir, ఏదైనా స్పైనల్ లీజన్ ఉందా క్వాడ్రిపెర్సిస్ కి, క్వాడ్రిప్లీజియా కి అండ్ రోడిస్?
లేజన్ ఇప్పుడు సడన్ గా ఎక్కడి నుంచి వస్తుంది?
Transverse myelitis.
No. See, this patient, what he said, the patient developed ARDS and you said no, Srinivas, Jekina, prone, no?
No, prone patient.
Yeah, prone patient during mobilization and shifting from prone to supine, it cervical spine injury might have happened.
Cervical trauma, yes, sir.
That could be the only reason for
ఇంకా ఉంటాయి reasons. They wanted to even tell that
దీంట్లో trauma
even transverse myelitis could ఉండొచ్చు.
Transverse myelitis.
So they elaborate. ఇంకా
sir, next I will do CSF, sir, to rule out to know albuminocytological dissociation, to rule out GBS. Next I will do NCS, nerve conduction studies, to rule out critical illness myopathy or neuropathy.
ఇంకా అంటే ఒకటి ఇల్నెస్ మయోపతి న్యూరోపతినా ఇంకేముంటుందా? రఘు
సార్.
ఇంకా అసలు చేస్తున్నాం కదండి, మనకు 2-3 పేషెంట్స్ డిఎం లెవెల్ స్టూడెంట్స్ అంటే చూస్తే కాల్చాలి. చదవండి. We can do our differential diagnosis ఉంది కదా. So what are the, can you say the nerve conduction studies లో how will you identify a myasthenia gravis, Eaton-Lambert syndrome, GBS, transverse myelitis, and critical illness, myopathy, neuropathy? How will you identify in NCS?
నర్వ్ కండక్షన్ స్టడీ ఒక పిక్చర్ ఏమన్నా అక్కడ పెట్టచ్చా? నెట్ లో చూసి ఎం శ్రీనివాస్ అక్కడ స్క్రీన్ మీద ఏమైనా పెట్టచ్చా డాక్టర్ రాణి? Can you hear me?
Yes, you are very clear, sir.
Hello, sir. Sir?
మీరు అక్కడ నెట్ లో ఓపెన్ చేసి నర్వ్ కండక్షన్ స్టడీ రిపోర్ట్ ఒకటి అందులో ఎట్లా అక్కడ కాన్ఫరెన్స్ లో చేస్తున్నారు అక్కడ పెట్టండి అని రిక్వెస్ట్ చేస్తున్నాను. శ్రీనివాస్ వస్తున్నాను. రైట్.
Okay, parలేదు. The other questions, no, we can discuss in the next class also these things. Please, any other questions from faculty? Other faculty?
సతీష్ ఉన్నాడా?
Mahesh,
Sir.
nice class. Suppose you
రెండు కనెక్ట్ అయినట్టే ఒకటి డిస్కనెక్ట్ చేయండి.
Mahesh, I'm audible now?
Yes, sir. Yes, sir.
Suppose you ventilate one patient, Myasthenia Gravis, and you did IVIZ and is improved muscle power, and you wanted to wean from the ventilator. Weaning and extubation your plan. How will you monitor the what this you told now 20, 30, 40 that FAC and negative inspirative pressure and forced expirative pressure? How will you monitor on ventilator patient? Just basic question only.
Yes, sir. If it meets the extubation criteria, then we'll extubate, sir.
See, there are two criteria you have mentioned. One is intubation criteria, one is extubation criteria, 20, 30, 40. ఈ రెండింటికి అవే పనిచేస్తుంది. See, 20, 30, 40 ఎలా ఎవాల్యుయేట్ చేస్తావు? ఇంట్యూబేట్ చేయాలంటే ఎలా ఎవాల్యుయేట్ చేస్తావు? ఎక్స్ట్యూబేట్ చేయాలంటే ఎలా ఎవాల్యుయేట్ చేస్తావు?
With the bedside measurements like vital capacity, peak flow rate, pulse rate, and BP, and ABG, sir. And our ventilatory test, the 20, 30, 40 rule, sir. If vital capacity of less than 20, NIP of less than -30, PU of less than 40 is to guide the intubation, sir.
What is less than 40? మళ్ళీ చెప్పు.
Positive expiratory pressure of less than 40 centimeter of water, sir. Meaning criteria 15, 20, 40, sir. FEC of more than 15 ml per kg, NIP of more than 20 ml per kg, PEP of more than 40 ml per kg is to guide the weaning, sir. And extubation criteria 25, 40, 50, sir.
Bedside PFTs can also be done using right spirometer.
In Google and Sinju.
So bedside PFTs like using de Bono's whistle, right spirometer.
In nerve conduction study, demyelinating disorders like GBS, nerve conduction velocity decreases, sir. Amplitude normal, sir. In axonal neuropathy, conduction velocity is normal because of myelination, but amplitude decreases, sir. In myasthenic gravis, decrement in the amplitude, sir.
రమణ ప్రసాద్ గారు క్వశ్చన్ పెట్టారు కదా, పీక్ 0.1 సెకండ్, అదేంటది ఆన్సర్?
Hello.
చెప్పండి రమణ ప్రసాద్ గారు.
If the patient is able to generate negative pressure at the beginning of inspiration, 0.1 second of the initiation of the inspiration, it is one of the criteria we can exhibit.
Sir, yes, it is true, but negative inspiratory force is slightly different from P.1. P.1 can be used for general criteria, like general patients also. And negative inspiratory force is an option that we can get in some ventilators where you can exactly measure the volume. మోహన్ సార్ ఏదో చెప్తున్నారు కదా.
ఏం లేదు సార్, అది మళ్ళీ ఎన్సివి వచ్చిందా, స్టడీ రాలేదా?
ఏం సార్? ఎన్సివి కంపారిటివ్ రావట్లేదు.
అయితే బేసిక్ అన్న పెడితే, అంటే నాకు కూడా చాలా మందికి బేసిక్ స్టడీ కూడా తెలియదు ఎలా చదవాలి. ఒకసారి పెడితే చదవచ్చాను అంతే, ఒకవేళ అతనికి తెలిస్తే చెప్తాడని.
సార్ బెటర్ అది ఒక క్లాస్ ఉంటేనే బెటర్, ఇట్ ఈస్ నాట్
అంతే. ఆ స్టడీస్ అన్ని ఒకసారి చెక్కినా, ఒకసారి నవ్ కండక్షన్ స్టడీస్ వాటి గురించి ఒకసారి మాకు ఎన్లైటన్ చేయ బాబు.
సార్ డెఫినెట్ గా మన ఈ రఘు అని శ్రావ్య ఉన్నారు. ఫస్ట్ మనం ఎవాల్యుయేషన్ ఒకటి ప్రెజెంట్ చేసి దాంట్లోనే ఇవన్నీ ఎన్సిఎస్ ఎట్లా ఉంటాయి, ఈ తర్వాత హౌ డు ఇన్వెస్టిగేట్ అని డిస్కస్ చేస్తే బెటర్ సార్.
అందుకోసమే ఒక స్టడీ మళ్ళీ నెక్స్ట్ క్లాస్ వీలవుతే నెక్స్ట్ మీదేనా?
మందేనా? సిటిజన్సా ఉంటే చేసేస్తాం సార్.
శ్రీనివాస్ ఎవరు చెప్తారో క్రిటికల్ ఇల్నెస్, న్యూరోపతి, మయోపతి వీటి మీద చెప్పినప్పుడు ఎన్సిఎస్ కూడా చెప్తే బాగుంటది. సో వి కవర్ ఆల్ ద న్యూరోమస్కులర్ డిసీజెస్.
డెఫినెట్లీ మేడం, అది మా రొటేషన్ ఉంటే మేమే చేస్తాం మేడం.
డైరెక్ట్ గా హైదరాబాద్ పెట్టేసేయండి, సిటిజన్ అనే కాదు, అపోలో కాదు, ఎవరో ఒకరు కదా పెట్టేసేయండి.
నేను చేస్తాను సార్. నెక్స్ట్ చేసిస్తాను. రఘు శ్రావ్య ఉన్నారు కదా, విల్ గెట్ ఇట్ డన్. ఓకే సార్.
Sir, how will you do this 20, 30, 40 on ventilator patient?
Sir, on ventilator patient 20, 30, 40 rule అనేది చేయడం కష్టం.
No, let them do. Let them tell.
సార్ కొన్ని NIF ఉంటాయి, బట్ లెట్స్ డిస్కస్. వాళ్ళు రెసిడెంట్స్ కొంచెం అన్ని మనం స్పూన్ తో ఇస్తుంటే కష్టం అవుతుంది వాళ్ళకి.
Hello, sir.
Yes.
The breath holding time, usually breath holding time of 30 to 40 seconds, that corresponds to a forced vital capacity of at least more than 25 ml per kg.
What is the normal breath holding time, and at what level you think that they're having a lung function good?
40 seconds, sir.
Normal. Okay. Less than how much is a respiratory compromise?
Less than 20 seconds is respiratory component.
Okay.
Likewise, we can also go for Snyder's breath matchstick blow test, or we can even go for De Bono's whistle blowing test and right spirometer and
Good. Next week we'll discuss.
maximum breath count. Hello.
Yes, you are right. Most of the things.
Anything else, David?
If nothing else, we will close the session, sir. Hello.
Sir.
Hello.
Hello. Madam, shall we close the session? Anything?
Yeah. Weaning process low, we usually look for rise in PCO2 levels in ABG, weaning time low, like over few hours of TPs or something. You check the ABGs and PCO2 continuously going up. That means their weakness is still persisting and it may be difficult to wean. So, and then they may need prolonged ventilation, consider tracheostomy. They may need BiPAP connecting to tracheostomy and home BiPAP. All these things will happen in prolonged cases. So assessing the buildup of PCO2 is also important.
David sir, oka last question. So why a carbohydrate like poor diet has to be given in a patient with CO2 retention? Treatment lo cheppinattunnaru kada. So for the students, why carbohydrate should be less?
So it will affect the respiratory quotient and carbon dioxide production.
How?
So the carbohydrate that produces respiratory quotient means with burning less carbohydrate, carbon dioxide is generated with that.
High carbohydrates causes increased CO2 due to increased metabolism and causes hypoventilation.
Yes, respiratory quotient of carbohydrate is less as compared to fats and proteins. So the production of CO2 is less. Yes, thank you.
Okay, if there are no questions, we will close the session. Thank you, Mahesh, for a nice presentation.
Thank you.
And,
thank you,
next,
sir, and thank you, madam.
I think it will next class will be on this neurological disorders, maybe.